Hey everyone, my name's Christina and this video is on organic acidemias. Picture yourself on your inpatient pediatric rotation. Your first patient is a female infant with nonspecific findings of poor feedings, hypotonia, and hepatomegaly. You, along with the intern and second-year resident, start to look at the patient's lab findings. You notice a metabolic acidosis and hyperammonemia. The chief resident turns to you and asks, what two acidemias should be in your differentials? We're going to be talking about organic acidemias, also known as inborn errors of metabolism. There are two specific acidemias you'll become familiar with, propionic acidemia and methylmalonic acidemia. By the end of this video, you should be able to 1. Identify where the errors in metabolism occur, 2. Describe how the errors occur, and 3. Recognize the clinical significance, diagnosis, and treatment management. So what are organic acidemias? They are abnormal metabolisms of organic acids that cause an accumulation in the blood or urine and an acidotic state. Over 60 types of organic acidemias have been described, but there are two high-yield types that are necessary to know for your board exams. That is propionic acidemia and methylmalonic acidemia. Both propionate-CoA and methylmalonyl-CoA are involved in the Krebs cycle. Propionate-CoA can be metabolized to methylmalonyl-CoA, which can be further metabolized to succinyl-CoA, a common pathway to the Krebs cycle, which we will go over in just a minute. Do you know what metabolites form propionate-CoA? Propionate-CoA is metabolized from all-chain fatty acids and branched-chain amino acids like valine, isoleucine, methionine, and threonine. Just a side note, propionate-CoA is a coenzyme A derivative of propionic acid. Propionate-CoA is then metabolized to methylmalonyl via the enzyme propionate-CoA carboxylase. Can you recall what vitamin this enzyme requires? Yes, biotin. So essentially, you get a propionic acidemia by a deficiency in either propionate-CoA carboxylase or biotin. And since this is a carboxylase reaction, we need ATP and CO2 in order to add a carbon molecule and form methylmalonyl-CoA. Methylmalonyl-CoA is metabolized to succinyl-CoA via the enzyme methylmalonyl-CoA mutase. And can you recall what essential vitamin is needed here? Yes, B12. A deficiency in methylmalonyl-CoA mutase or B12 will cause methylmalonic acidemia. Now that we have succinyl-CoA, this is a key player in our favorite reaction, the Krebs cycle. Let's quickly go over the Krebs or TCA cycle. So if you recall, we can get citrate from acetyl-CoA via glycolysis, right? Citrate is converted to isocitrate, which is then converted to alpha-ketoglutarate. Then we can get succinyl-CoA directly from citrate and acetyl-CoA or from a body of methylmalonic acid in the reaction we just went over. Succinyl-CoA is converted to succinate, then malate, then oxaloacetate, which can either form citrate and the cycle keeps going, or it could then form phosphophenylpyruvate or PEP, which can initiate gluconeogenesis and eventually be converted to glucose, which can be used as an energy source. For more information on the TCA cycle, check out our Krebs cycle video. Okay, so why are these reactions important? Well, one reason is gluconeogenesis. Our body can metabolize propionic acid and propionate-CoA during starvation periods via all-chain fatty acids and amino acids, which can be used as energy sources to maintain blood glucose. Can you think of any other ways our body maintains blood glucose during days 1 to 3 of starvation? Well, in addition to gluconeogenesis via propionate-CoA, our body can initiate gluconeogenesis from peripheral adipose tissue, such as glycerol, and release of free fatty acids. Our body can also initiate hepatic glyconeolysis to maintain blood glucose levels, and by our muscle and liver, which shift fuel use from glucose to free fatty acids. So on to the clinical aspect of the disease. Gluconeogenesis is partially impaired, so you can expect to see periods of hypoglycemia. However, since our body has additional ways in producing glucose during periods of fasting, this isn't the most severe finding. The buildup of propionate-CoA leads to very high levels of propionic acid in the blood, hence the name propionic acidemia, and decreased levels of methylmalonic acid. Organic acidemias occur in infancy and cause classical findings of poor feeding, vomiting, hypotonia, and anion gap metabolic acidosis. It causes an acidotic state by inhibiting gluconeogenesis, which causes decreased fasting blood glucose levels, causing a ketoacidosis, which results in a high anion gap metabolic acidosis. You can also see hepatomegaly, seizures, and hyperammonemia, which is caused by inhibition of the urea cycle, though the exact pathophysiology is not well understood. This is usually diagnosed during the first week of life and is generally made via a urine sample, which reveals abnormal levels of organic acids. Blood work can also reveal hypoglycemia, metabolic acidemia, and hyperammonemia, as we just mentioned above. Diagnosis in the first 24 to 48 hours is vital and can prevent chronic sequelae from occurring. Treatment can be either acute or long-term. During acute episodes of acidosis and dehydration, suppurative therapy such as fluid and electrolyte replacement and ensuring appropriate nutritional and caloric intake is necessary. Long-term treatment includes a low-protein diet excluding the metabolites of propionic-CoA, which again are valine, all-chain fatty acids, methionine, isoleucine, and threonine, which you can remember by the acronym VOMIT. Okay, time for a quick flash quiz. How does a high anion gap metabolic acidosis occur in organic acidemias? This occurs due to inhibition of gluconeogenesis, which leads to low blood glucose levels and increased ketoacidosis. The ketoacidosis results in high anion gap metabolic acidosis. This lab value can also support the diagnosis of organic acidemias. Okay, so the bottom line is, there are several organic acidemias, but the two most important are propionic acidemia and methylmalonic acidemia. For propionic acidemia, this occurs due to deficiency in propionic-CoA carboxylase, or biotin, and in methylmalonic acidemia, this occurs due to deficiency in methylmalonic-CoA mutase, or B12. It presents in infancy with many different clinical features, including poor feeding, vomiting, metabolic acidosis, and hyperammonemia. Early diagnosis is crucial and can be made through both urine or blood samples. And lastly, treatment includes both acute and long-term therapies. Thanks for watching this video. If you enjoyed it, don't forget to give it a thumbs up.